Okay, welcome everyone. We're going to talk today about polyps and some of the precursor lesions for colon cancers. This may be very easy for many parts of this, but there also are some complex parts that would be helpful to be aware of. In GI pathology, this is a very common problem of how to classify the polyps, how frequently to follow the patients, and what the findings mean. So understanding and differentiating polyps is very useful if you're going to see very many colon biopsies. So what I'd like you to be able to recognize after you have listened to this and reviewed the notes is I'd like you to be able to see and differentiate the epithelial polyps from the mixed polyps that occur here. And very appropriately is to use the right terminology, to use the right words to convey to the clinician how is this polyp going to behave and what other implications may be there. And that requires that you understand the follow-up for these patients. So oftentimes we see polyps that look like de novo polyps. So in other words, an original polyp. But this is actually a polyp that is occurring in the setting of inflammatory bowel disease, which we talked about last week. So even though the rest of the mucosa looks very normal, this little polyp here that we see has a variegated appearance and therefore is going to be more likely to be a inflammatory polyp. When we have a situation like this, then you can see lots of little polyps, and it's easier to say, oh, this is the backdrop of inflammatory bowel disease with lots of ulcers, and these are normal inflammatory residual polyps. On biopsy, these kinds of polyps always have some level of inflammation. If we looked at this, we might say, if this was a biopsy, not a polyp, we would say, well, maybe this is inflammatory bowel disease because we have crypt abscess, we have distortion of the glands, right? We would remember that. And here we might even see some gland damage and inflammation. But when this is occurring in the setting of a polyp, it's more likely to be an inflammatory polyp rather than a neoplastic polyp. So these inflammatory polyps are also very commonly seen. One little trick is that sometimes we can have a very atypical stroma in these. That should not be interpreted to mean that there's sarcoma or this is sarcomatoid carcinoma that is occurring here. This is a bizarre stroma, but not a neoplastic stroma. So being aware that this can occur is very useful when you see it, to not overreact. We also talked a little bit about the inflammatory changes that can occur when you get mucosal prolapse. So here notice we have squamous mucosa here and on the surface here. So this is right at the anal-rectal junction, and this mucosa has prolapsed out. It's extruded out through the anus, and that creates stretching of these glands and some surface erosion. Sometimes we'll also see muscle pulled up in amongst the glands. So this can have an invasive pattern. It can look like invasion. But the cells are very well differentiated, and we see ulceration of this prolapse kind of change. Now this can also happen with diverticulus, that ulcerates out. Here's the surface ulceration that we see here. This is an ischemic type of change. And sometimes this ischemic change or inflammatory change will produce what's called an inflammatory cap. So we get this very ulcerated surface, but lots of neutrophils, lots of fibrin that forms this cap like you'd wear on your head. It's a cap that you wear on the polyp. And this is an inflammatory process, not neoplastic. Now, sometimes this might be infectious. The differential might include an ischemic colitis or Clostridium difficile, as we talked about. But usually this is very isolated or a single spot. Do you have a question? Oh, okay. So this entity, colitis cystica profunda, is also another challenging differential when we see it histologically. Primarily, this is presenting as a polyp, but in so presenting, it has mucosa, glandular tissue in the wrong place, very deep. Profunda usually means deep. So to read this, you would say inflammation, cystic change, deep. That's all that this means. It's a funny Latin word, but it's very easy to remember once you know the roots. The challenge is that sometimes this is, can look like well-differentiated carcinoma because these are displaced and there's cystic change and sometimes even mucin outside of the gland. So it can have a little mucin pool. So here's a very nice low-power image. Here you see the name. Dilated cystic glands deep to the normal mucosa. And here you see a little extra mucin pool. So if this is carcinoma, then they haven't treated it well. It will still have some residual. But if we recognize it as colitis cystica profunda, they don't need to biopsy, they don't need to follow up. It's a variant with no significant risk to the patient.
So how could we differentiate it to the mucinous carcinoma? Perhaps if there is another tumor in other size.
So the question is, how can we differentiate it from mucinous carcinoma? So first of all, there's no surface lesion. So there's no surface in situ component or adenoma or anything like that. So no dysplasia is seen.
But there is another tumor.
So not a primary tumor. So could it be metastatic tumor? Well, there will be very well differentiated tissue in here, and there should also be some trace of lamina propria type tissue. So a few plasma cells and lamina propria type vessels that say this is just displaced mucosa, not neoplasm. And this is just a ruptured gland rather than an invasive gland. In the pool of mucin, you will not find free-floating cells. Histiocytes, yes, but no cancer cells, no signet ring cells, sorts of things. So those are the main clues to differentiate. This is the other example of mucosal prolapse where, if you can imagine, this little projection here was actually through the wall. So this was a diverticulum that has been everted or returned to the lumen, and it's very long, broad, and you can see mucosal changes like those that we saw here on the surface, these sorts of changes, muscle involvement pulled up can also be seen in diverticular disease. Sometimes they may just biopsy the surface of this, and then it's hard to say other than it's not neoplastic, not dysplastic. So there are 3 or 4 polyposis syndromes that are frequently present in the colon, and these are unusual. I don't see very many in my practice. You may never see one here because they're even less common in Asia. But these are juvenile polyposis, Polyps polyps, Cronkite Candida polyposis, and Cowden syndrome. I won't spend a lot of time on these, but juvenile polyps have several variants. This might be the one you would be more likely to see. There is a sporadic type, which has some no family history and very few of these, and essentially no risk of malignancy. In contrast, when they present with multiple polyps, and especially if they present fairly early in life, they tend to be fatal. So they can develop some problems because they get neoplasms at a young age. And these are due to germline mutations or deletions involving P10 or BMPR1A. And that's a common mutation for all 3 of these syndromes. And you can see the details on this chart and look at those later. I don't think it's important for you to understand the differentiation of these, just to know that there are several possible ones, and they all tie back to some similar genetic changes. This is what they look like. Again, this is a polyp with dilated glands. So like Cystica profunda, but these glands are deep and dilated, and it actually is a neoplasm. The other thing that you will see is in the lamina propria, these are dilated, and there can be edema and small crypt abscesses here as well. So this can be a little bit difficult to distinguish from, say, an inflammatory polyp, some of these other disorders. So understanding, is this one, multiple, age group will be different. Inflammatory polyps usually aren't presenting in young adults or children and so forth. The stroma is expanded and may also contain neutrophils and be edematous. Here is dysplasia developing in one of these, reminding us that this is neoplastic potential. So if we see any degree of dysplasia, it's not an inflammatory polyp, it's going to be a juvenile polyp or one of these other polyps that can develop dysplasia. Pott-Jaeger's polyps, as we have talked about elsewhere, these are hamartomas, and so we see muscle associated with them, and the kind of epithelium that is native to wherever it's occurring. Sometimes this has ovarian manifestations or other organs as well. So here's an example. You remember the arborizing, the branching, smooth muscle in these polyps. And the mucosa can be very florid and hyperplastic appearing. Here's more reminding, when you see smooth muscle like this in the polyp, it's more likely to be a Pott-Jaeger's type polyp. Sometimes these polyps also will have cystic dilatation and displacement, maybe with gland rupture. So how do you distinguish this from colitis cystica profunda? Well, you have the arborizing, branching, smooth muscle up in the polyp up here that would differentiate it from that. Okay. Cowden's syndrome, I don't think I've ever seen a polyp like this. I had to pull this from a textbook. These essentially have normal-looking glands, but a very edematous stroma, slightly fibrotic, and then the stroma adjacent to the polyp will also be edematous. There's usually not dysplasia associated with this and normal epithelial components. So they tell you it's a polyp, it looks like normal mucosa. If the stroma is slightly fibrotic, you might think about this, but this is usually not a pathologist diagnosis as Cowden syndrome. This is usually a, oh, he has these kinds of polyps, probably it's this syndrome, and then they may do genetic testing. Cronkite candida syndrome will usually represent juvenile polyps, but the intervening mucosa will also be edematous or abnormal. So it's a slight variation on juvenile polyposis, essentially. Here you see the very edematous stroma in between these type of glands. Again, this is not something that I have seen personally. It's not common in our practice. But if you're seeing a lot of people from the right genetic disposition, you might see this.